Hello everybody. It's a great honor for me to be here for this web conference. I will speak about peritoneal surface malignancies, which is my favorite topic. And the goal of this presentation will be not to perform an exhaustive review of all the literature on this big topic, but to give you my personal view regarding the experience that we have in our institution and the interpretation of recent studies and literature data. We will speak most of curative treatment, but also on preventive and some palliative treatment. This is my disclosure. Peritoneal surface malignancy is probably one field in oncology for which we did the most important progresses in terms of survival during the 30 past years. We moved from palliative treatment to curative treatment for some selected patients. I have the privilege to be at the head of general surgery department, specifically dedicated to peritoneal cancer. I follow Professor François-Noël Gillier, who did the first HIPEC in 1989, and with the help of many experts and surgeons, we are performing now every year 250 cytoreductive surgery per year and more than 300 PPAC, which is palliative treatment that we introduced in our department since 3 years. So when we look at the evolution of the survival of our patient in the center, the hospital center Lyon Sud, you can see that when I began my residency, the median survival that the patient that we treated was only 6 months. And year after year, we improved the prognosis of all these patients, whatever the etiology is, to have now for all the etiology a median survival of more than 50 months. Of course, the impact of the etiology of peritoneal surface malignancy has great influence. You can see that on the top, the best survival were obtained for Pseudomyxoma peritonei or for peritoneal mesothelioma, followed by the curve of ovarian and colorectal carcinomatosis. The lower curve is the gastric one. But if you can see, we speak not only about 5 years survival rate, but also about 10 years survival rate. So we may have, for selected patients, a very long-term survival. So peritoneal metastasis is a loco-regional disease, and there is a strong rationale to apply a loco-regional treatment. Schematically, we will treat the microscopic disease with the surgery, and this is the most important part of the treatment, by doing cytoreductive surgery and peritonectomy procedures. We will have to treat, if we want to cure the patients, the microscopic disease, and it will be the role of intraperitoneal chemotherapy, and especially of HIPEC, which combine intraperitoneal chemotherapy with hyperthermia. But we will have to take into consideration also the metastatic, the systemic disease, by incorporating the use of intravenous chemotherapy for patients that will not develop only peritoneal metastasis, but also systemic disease. Regarding the surgery, when the tumor nodules is involving the parietal peritoneum, we will perform the parietal peritonectomy. You can see here an example under the diaphragmatic cupula in the entire parietal wall. The problem is often when the tumor nodules is involving the organ, and when we have to combine the organ resection to make a complete cytoreductive surgery, which represents the most important prognostic factor. To treat the microscopic disease, the HIPEC, the hyperthermic intraperitoneal chemotherapy, has also a strong rationale. First, you have the pharmacokinetic advantages of intraperitoneal chemotherapy that can deliver directly in contact with cancer cells high dose of chemotherapy with limited dose of systemic passage that limits the toxicity. The cytotoxicity of hyperthermia was demonstrated at a level of more than 41, 42 degrees. There is a synergistic effect between hyperthermia and some anti-cancer drugs like cisplatinum, mitomycin, doxorubicin, and you will apply this intraperitoneal chemotherapy just after the surgical procedures, after the liberation of all the adhesion, avoiding the problem of cancer cells entrapment. The inconvenience, of course, of this treatment is this is a single shot treatment, so you will have to treat and to eradicate the microscopic disease in one time, in contrary to systemic chemotherapy that can be repeated. Two big HIPEC techniques was developed. The open coliseum technique developed by Paul Sugarbaker, when you deliver the chemotherapy with the abdomen open, and the closed technique that was developed by François-Noël Gilly, Marcello De Racco in Italy. All around the world, approximately half are using open technique, half are using closed technique, and no technique demonstrated its benefit on the other. So now, how can we select the good candidate for a curative treatment for peritoneal metastasis combining cytoreductive surgery and intraperitoneal chemotherapy? The first thing is to take into account is the patient condition, age, performance status, and motivation. The other important part is the center where the treatment will be delivered. The surgeon has a major role, but he should be not alone, but with a multidisciplinary team. He should have sufficient skill to be able to deliver intraperitoneal chemotherapy. You should also take into account the tumor, the etiology of the primary seat of the cancer, the response to systemic chemotherapy, the pathology, and more molecular and genetic factors. And finally, you also have to take into account the peritoneal disease, especially the extent of this peritoneal disease, the possibility of performing a complete cytoreductive surgery, and of course, the presence of extraperitoneal disease that may have a strong influence on the prognosis. For the current practice, the first message is that a curative treatment of peritoneal carcinomatosis should be considered at the time of the diagnosis and not following failure of different palliative treatments, surgery or systemic chemotherapy. You have to select the good patient regarding its condition. The combined treatment, cytoreductive surgery and HIPEC remains an aggressive therapeutic approach with a high rate of mortality and morbidity rate. So you have to do a strong evaluation of the general status and on the motivation. You should reserve these procedures to patients with performance status 0 to 1 with no cardiac, respiratory, or renal severe disorders. For these patients that often have systemic chemotherapy, you should schedule the procedure 1 month following the last cycles of chemotherapy, and you should evaluate its psychology that should be strong. What about age? For many years, these kind of procedures were reserved for patients less than 70 years. So we looked in the French database on a large retrospective study comparing patients that were operated after 70 years and before 70 years. We did not find any difference in terms of prognosis, and we did not find also any significant difference in terms of postoperative results, even if the mortality rate was a little higher in the patients over 70 years. So IH does not constitute an absolute contraindication for as a selection of patient for a curative procedure. The centers is very important, and we cannot perform this kind of complex, costly, and long procedures everywhere. In expert center, you will have a better patient selection, you will have a lower complication rate, and you will have also a higher rate of complete cytoreductive surgery, so a higher rate of curative treatment. We recommend in every country that an expert centers in the management of peritoneal surface malignancy that should be contacted at the time of the diagnostic, the diagnosis to evaluate how to organize the overall therapeutic management. It's for each case very difficult when you are in the abdomen in front of peritoneal disease to take the good decision regarding the patient condition, regarding the extent of the disease, regarding the possibility of a complete cytoreductive surgery, of what surgery you should do. You should take into account the hope of cure or remission that you can lead to your patient, and you can find a good balance between this and the risk of postoperative complication or sequela that you confer by doing this kind of surgery. I think that this Western film and the title of this Western film illustrates well the position of the surgeon during a cytoreductive surgery in front of peritoneal disease. You can be the bad by doing complete cytoreductive surgery, but too extensive, leading to very high rate of and hard complication or sequela. You can be the ugly, doing non-adequate complete cytoreductive surgery with early recurrence because of insufficient surgical skill. You should be the good for each patient, and it's not so easy for each case. In France, the National Cancer Institute decided to establish, especially for rare peritoneal disease, a network which is called RENAPE in order for patients to be adequately treated and to improve the results of patients with peritoneal surface malignancy. We have expert centers that are performing the most difficult case. You have the reference centers that are performing more simple case. This network is not only a network of surgeons who has a pivotal role in the management of this kind of disease, but also include specialized pathologists, specialized radiologists, and specialized oncologists. So how to select now regarding the tumor? The gold standard cytoreductive surgery and HIPEC represent the gold standard for the treatment of peritoneal mesothelioma. You can see in blue the median survival that you may obtain with systemic chemotherapy alone, and you can see that the median survival did not exceed 1 year, and in the lower part, the median survival that was obtained by the combination of cytoreductive surgery and HIPEC. For this rare peritoneal disease, several years ago, we reported a big registry of more than 400 patients that were treated with cytoreductive surgery and HIPEC, and you can see that the median survival was more than 50 months, and that HIPEC was identified as an independent prognostic factor. The other good indication of this combined treatment is the treatment of Pseudomyxoma peritonei. You can see on the left that in the French experience, the best results were obtained with open or closed procedure for HIPEC and were better than intraperitoneal chemotherapy without hyperthermia. The most important prognostic factor in this disease is, with the pathology, the possibility of complete cytoreductive surgery. But when you are not able to remove all the disease and let in the abdomen only minimal residual disease, you obtain the same good survival results. Pseudomyxoma peritonei is probably one of the most challenging peritoneal surface malignancy for surgeons because you have a big amount of tumor. When you open the abdomen, you often do not know where exactly you are, but especially in low grade, even if you have a large amount of tumor, you are able to perform with a reasonable procedure a complete cytoreductive surgery, and when it's combined with HIPEC, you may obtain a very long-term survival. One word only, because I have no time, about ovarian cancer. As you know, we have in 2018 phase 3 trials that validate the use of HIPEC in combination with cytoreductive surgery that was published in the New England Journal of Surgery. The patients that were not able to be completely resected at the diagnosis received 3 cycles of neoadjuvant systemic chemotherapy by carboplatin paclitaxel, and the HIPEC was randomized as during the interval complete cytoreductive surgery. This study was very important because it was the first randomized study that demonstrates the benefit of HIPEC adding to a complete cytoreductive surgery for a good indication, which is represented by ovarian carcinomatosis. And you can see that in this study, the gain in terms of median survival was 1 year, which was never reported by some anti-cancer agents. The HIPEC that was used in this study was with cisplatinum at 100 milligrams per meter square for 90 minutes in 3 fractions. One thing which was, I think, very important is that this HIPEC did not add any complication to the surgery, did not delay the postoperative chemotherapy. During many years, we had some problem with the use of HIPEC using cisplatinum because of some renal insufficiency, and it appears that the use of sodium thiosulfate resolved the problem of renal insufficiency that was not reported in this study. Now, a most common indication, the colorectal peritoneal metastasis. As you can see, the evolution of median survival for peritoneal metastasis from colorectal cancer increased of 10 months each 10 years since the first randomized trials that demonstrate the benefit of cytoreductive surgery and HIPEC over systemic chemotherapy alone. And now, with cytoreductive surgery alone, without HIPEC, we can consider that we can offer to patients a median survival of 40 months. What are the reasons for the success? Certainly, the key role is represented by the cytoreductive surgery and the possibility of doing a complete cytoreductive surgery. Secondly, we improved our patient selection, and the patient that we operate now are probably not the patient that we operate before. Of course, the progress of systemic chemotherapy that better control the systemic disease and also the peritoneal disease. And finally, also the establishment of specialized centers that are involved into peritoneal surface malignancies. The question that is still open is the role of intraperitoneal chemotherapy and HIPEC in the overall management. When you look at the effect of systemic chemotherapy on patients with colorectal cancer and metastatic disease in the big randomized trials that evaluated systemic chemotherapy, you can see that lung metastasis had a significant better prognosis than liver metastasis, that have a significant better prognostic than patients with peritoneal metastasis. And we can consider that the median survival of peritoneal metastasis treated only with systemic chemotherapy is approximately 16 months. We also know, because of the effort of the Netherlands colleagues, that the surgery and HIPEC did better than systemic chemotherapy. This randomized study was stopped after 2 years because of the big difference in favor of the couple surgery and HIPEC. Since these randomized trials, many case control studies also demonstrated the benefit of the combined treatment when compared with systemic chemotherapy alone. It was the case of the Elias study on very localized peritoneal disease. It was also the case in the USA with the study by Franco for more evolved peritoneal disease. The American Society of Peritoneal Surface Malignancy also reported very interesting prognostic factor, which is called peritoneal surface disease severity score, which take into account 3 very important prognostic factors: the presence of clinical symptoms, the extent of the disease, and the pathology. And they identified 4 groups of prognosis regarding the presence of this prognostic factor. And they showed in this big retrospective studies of more than 1,000 patients that the couple cytoreductive surgery and HIPEC did better, not only for good prognostic patients, but also for bad prognostic patients, because you can see that in PS-DSS4, with chemotherapy alone, you have just 6 months of median survival, whereas you have 28 by performing cytoreductive surgery and HIPEC. We also demonstrated that it's possible to cure patients with peritoneal disease from colorectal cancer, and in the selected patients in expert centers, the rate of this cure patients is more than 15%. When you select the patient with the systemic chemotherapy, you can increase your results and your median survival. And for patients that respond preoperatively to systemic chemotherapy, median survival can exceed 60 months. So, because of all these results, in 2014, during the PSOGI Congress that include many experts all over the world, and in many national guidelines, cytoreductive surgery and HIPEC was considered as the standard of care for selected patients with peritoneal metastasis secondary to colorectal cancer, when the disease could be completely resected and in experienced centers. But all studies that I showed to you compared systemic chemotherapy alone versus the combination of cytoreductive surgery and HIPEC. And the exact role of HIPEC was not determined. This is the reason why we decided to conduct in France this interesting randomized trials to try to demonstrate the role of HIPEC in the overall management. All patients had complete cytoreductive surgery. All patients had perioperative modern systemic chemotherapy, and we randomized HIPEC intraoperatively. The results of this important study was presented in ASCO meeting last year by François Quenet. We decided to choose the HIPEC with high dose of oxaliplatin with bidirectional chemotherapy using IV 5-FU for 30 minutes. Why did we choose this kind of HIPEC? Because we have a big pressure of the medical oncologists to use oxaliplatin, which has good results by intravenous administration. Because also Dominique Elias and Gustave Roussy did the phase 2 trial, pharmacokinetic phase 2 trials, and reported high median survival that was never reported on patients that were strictly selected. And the duration of HIPEC was only 30 minutes instead of 90 minutes, which was the usual duration of HIPEC before. Moreover, we need at this point of time homogeneous protocol of HIPEC, so everybody in Europe, in France, and in other countries decided to use HIPEC with oxaliplatin to treat patients with peritoneal disease from colorectal cancer. So one remark about this study, very strictly selected patient. As you can see, regarding the patients that were included, only 1/4 were finally randomized, mostly because of non-resectable disease. Second comment, the PCI, at the time of the study, we did not know the strong impact of the PCI on the results. And as you can see, the median PCI was not exactly the same in the HIPEC group and in the non-HIPEC group, in defavor of the HIPEC group. The mortality rate was very low and were the same in the HIPEC and in the non-HIPEC group. Regarding the type of complication, you can see that the peritoneal hemorrhage were a little higher in the HIPEC group, which was one of the problems of the HIPEC using high dose of oxaliplatin. And at 60 days, the rate of complication were also higher in the HIPEC group. The two big surprises that we have regarding the survival result was first, the very high median survival that was not expected by the use of cytoreductive surgery alone of more than 40 months. And the second surprise was the absolutely no effect of the use of HIPEC with this protocol. Regarding the disease-free survival, it was a little better in the HIPEC group, but the difference was not significant. Only one subgroup had a better prognosis in the HIPEC group. It was the subgroup of patients with intermediate PCI between 11 and 15. So for many oncologists and for many colorectal surgeons, the conclusion of this study was that HIPEC did not improve the prognosis of patients currently treated for peritoneal metastasis. But this is not the exact and the correct conclusion. This is HIPEC with oxaliplatin for 30 minutes at high dose at 43 degrees that did not improve prognosis patient of colorectal peritoneal metastasis. And probably that's what is called now the quick ship was not the ideal HIPEC to treat peritoneal metastasis from colorectal cancer. When you look at the literature, you have no experimental rationale for hyperthermic augmentation with oxaliplatin. The effect of oxaliplatin alone, even by intravenous administration, it's just 20%. we discovered by the use of this protocol that we had a higher rate of hemorrhagic complication. We may suppose also that patients that were heavily treated by previous systemic chemotherapy using oxaliplatin lead to oxaliplatin resistance for these patients. There is a clear insufficient duration, and I will demonstrate that 30 minutes it's not sufficient for the drug exposition, but also for hyperthermia exposition. And we use a carrier solution, which was the glucosate, which is well known to be a pro-carcinogen agent and limits the defense of the peritoneum. When you look at the literature, you have a strong rationale for the use of mitomycin, cisplatin, doxorubicin, because this is drugs that are potentiated by heat in vitro. And you have some experimental studies that demonstrated that HIPEC using this drug did better than cytoreductive surgery. But you do not find any kind of study like that for oxaliplatin. Moreover, we looked in the French database if HIPEC with this dose of oxaliplatin really increased the hemorrhagic complication. And it was the case. As you can see, the rate of hemorrhagic complication was 3% only with other drugs, whereas it was 5 times higher with the use of oxaliplatin, which was an independent prognostic factor of hemorrhage. And we all know that if you have hemorrhage, you will have transfusion, and we all know the bad impact on the prognostic on metastatic cancer patients of using transfusion. Moreover, the rate of complication that was not so high, but that was higher in the group of patients treated with HIPEC with this protocol. When you look at the most important series into the literature, you can see that with the use of mitomycin, cisplatin, and doxorubicin, the rate of morbidity is systematically less than 30%, whereas it was systematically more than 40–50% with the use of oxaliplatin. And we all know also the bad prognostic impact of postoperative complication on survival of patients with metastatic disease. This is an independent factor of poor prognosis. It delays the restart of postoperative chemotherapy. So in USA, HIPEC with mitomycin C remained the gold standard, and the HIPEC that was recommended by this consensus for the treatment of peritoneal disease from colorectal cancer. But when we look at some studies that try to compare the HIPEC with mitomycin C and with oxaliplatin, you don't find a benefit in favor of HIPEC using mitomycin C. But the problem of these studies, as everyone did for 10–15 years, HIPEC with oxaliplatin, is that you compare two different periods. The old period, during which patients were treated with HIPEC using mitomycin C, and the most recent period during which HIPEC was performed with oxaliplatin. The only study that really compared two patients that were operated in the same period is the American Society of Peritoneal Surface Malignancy, that evaluated more than 500 patients treated with both HIPEC. And you can see that in this retrospective study that has also a lot of bias, HIPEC with mitomycin C did better than HIPEC with oxaliplatin. In USA, HIPEC with oxaliplatin is using with a lower dose and for a more longer duration, which is probably one of the key of the efficiency of this HIPEC. And when they compared HIPEC with low dose of oxaliplatin and HIPEC with mitomycin C, they did not find any difference, especially in terms of hemorrhagical complication. So probably that the problem of hemorrhagic complication is due to a too high dose. What about the duration? You can see here in this experimental study that evaluate the effect of oxaliplatin of cancer cells death, that the duration of exposition have a strong influence. And this influence is noticed not only at 37 degrees, but increased at 42 degrees. So the duration of drug exposition has a strong influence. The duration of hyperthermia exposition has also a strong influence. And 30 minutes, as you can see here on this graph, is probably not sufficient. Kurt van der Spitten is a Belgian surgeon that worked a lot on pharmacokinetic on HIPEC, and he recently came back because of the negative results of the PRODIGE 7 study to the lab to try to find an explanation. And he found for results that were not published that oxaliplatin exposed to cancer cells at 30 minutes does not lead to any apoptosis, whereas oxaliplatin at 120 minutes leads to a complete apoptosis of the cancer cells. So my conclusion of HIPEC in colorectal peritoneal metastasis is that a complete cytoreductive surgery is the key of curative treatment, and should be 41 months should be now the median survival of reference for patients treated with a curative intent. Because of this level, all patients with peritoneal disease with colorectal peritoneal metastasis should be evaluated for curative procedures in specialized centers. The HIPEC with the Elias protocol, the quick ship, should be abandoned because of the negative study of PRODIGE 7. But HIPEC has still a strong rationale to treat the microscopic disease in combination to cytoreductive surgery, and its evaluation should be continued. But the choice of HIPEC should integrate an active molecule on colorectal cancer with an intraperitoneal administration, a molecule potentiated by hyperthermia, an adapted carrier solution, a sufficient duration for the drug exposition, but for also the hyperthermia exposition, and should lead to a limited risk of complication. Moreover, if we want to do new randomized trials, we should be probably less ambitious, especially in colorectal metastatic disease, for which we have several procedures, several cycles of systemic chemotherapy, several treatments. Recently, the BIG RENAPE group in France tried to establish standardized protocols, because one of the main advantages of our randomized trials was that we did an homogeneous HIPEC, and we decided that we will recommend prospectively for the treatment of peritoneal disease from colorectal cancer the use of mitomycin C with the fixed dose in free fraction, or the use of oxaliplatin but with a lower dose and with a longer duration. For patients with recurrence, the combination of cisplatinum and mitomycin appears to be, into the literature, the best option. So we should move to personalized treatment of peritoneal metastasis from colorectal cancer, as the medical oncologists are moving to personalized treatment for the treatment of other metastatic disease. We should probably work on the identification of patients with systemic metastatic disease That represents 2/3 of patients. The patients with peritoneal disease will also have a risk of recurrence outside. All intraperitoneal recurrence are probably not peritoneal disease. There is some lymph node, there is some systemic disease, and this kind of peritoneal disease probably do not need any intraperitoneal chemotherapy, and we should identify this kind of patients. I know that in PRODIGE 7 patient study, some patients like that were included, and we should also work of new intraperitoneal drug and regimen adapted to molecular profile. So now one word on the gastric peritoneal metastasis. There is also a possibility of cure this worst prognosis evolution. We looked into the French database and we selected patients that were treated with a curative intent to try to identify the percentage of patients that could be considered as cured, defined as a disease-free interval of at least 5 years. And we found an interesting rate of 10% of patients that could be considered as cured over a long period and in a population that was strictly selected. You can see that all the peritoneal disease were synchronous. The median PCI of patients cured were very low and not more than 6. So peritoneal disease that could be diagnosed only by a laparoscopic approach. All were treated by a complete cytoreductive surgery, but some of them had a poor pathology with the presence of synecdoche cells. We also did a retrospective study with a propensity score analysis, which is the CITOSHIP study that was published last year in the Journal of Clinical Oncology with the famous esophageal surgeon Christophe Mariette, who unfortunately left us too early. We were able to compare 180 patients treated by cytoreductive surgery and HIPEC to approximately 100 patients treated by cytoreductive surgery alone. With the help of the propensity score, it was possible to make two groups strictly comparable, except for one thing, the PCI, which has a very strong influence. But the PCI was higher in the HIPEC group than in the cytoreductive surgery group. And the median PCI was 6 in the HIPEC group and only 2 in the cytoreductive surgery group. Despite this poor prognostic factor in the HIPEC group, in all the models, HIPEC with cytoreductive surgery did better in terms of overall survival and disease-free survival when compared to cytoreductive surgery alone. And when we looked at the post-operative results, HIPEC did not have any morbidity to the cytoreductive surgery. And when you look at the HIPEC that was performed in this study, most of them were performed for 90 minutes, and most of them were performed with intraperitoneal drugs that were potentiated by heat, cisplatinum, and mitomycin C. So now, sometimes when you have an expert centers in the management of peritoneal surface malignancy, you may be solicited by for unusual indication. Unusual indication, rare indication, it's impossible to have a big series. This is the reason why we decided with the BIG RENAPE and the PSOGI subgroup to make this registration to try to have some answer on this unusual indication of HIPEC. As you can see, we were able to collect 850 procedures from 53 centers, and we'd find some interesting results of very strictly selected patients for cholangiocarcinoma, for example. We compare these very strictly selected patients to patients who treated and comparable by palliative systemic chemotherapy only, and you can see that we obtain survival significantly better in the group treated by cytoreductive surgery and HIPEC. We find also, especially for patients that could be treated by complete cytoreductive surgery, interesting results and long-term survival for patients treated with urachus cancer, for pancreatic cancer, even if it represents only 30 patients, for hepatocarcinoma, and from rare ovarian tumor. The best results of the combined treatments were obtained for mucinous ovarian tumors that do not respond well to systemic chemotherapy. So if we want to make summarize the good indication regarding the etiology of the combined treatment cytoreductive surgery and HIPEC, we can recommend it for Pseudomyxoma peritonei, peritoneal mesothelioma, colorectal peritoneal metastasis or metastasis from appendiceal cancer, gastric cancer but with limited PCI, ovarian cancer as interval surgery in patients selected regarding their general status, their possibility of complete cytoreductive surgery. You can say yes for some patients with good tumor biology that respond well and for a long time to systemic chemotherapy, even if it's a peritoneal disease from pancreas, bile duct, or gallbladder cancer. So now the peritoneal disease, whatever the etiology is, the two major prognosis is the surgical residual disease, the possibility of completeness of complete cytoreductive surgery, and the disease extent. You can see that in colorectal carcinomatosis, in pseudomyxoma peritonei, each time you are able to do a complete cytoreductive surgery, the results are better. This is the most important prognostic factor. You can find also its great influence on gastric carcinomatosis and also on ovarian carcinomatosis. The other very important prognostic factor is the disease extent. We have an objective tool to evaluate this disease extent, which is the Peritoneal Cancer Index from Paul Sugar-Baker. All the expert centers are using, of course, this tool to evaluate the disease extent, which is not for a non-expert surgeon always easy to evaluate, to use. This is the reason why we developed this internet tool in order to allow all the surgeons, but also the radiologists, the pathologists, to use this PCI to evaluate the disease extent. It's very easy to complete, and you can add to your operative report the data sheet to summarize the summary of your surgical exploration. As you can see, the PCI is also a strong prognostic factor in colorectal carcinomatosis. In all retrospective study, each time you gain 1 point of PCI, you will lose 5% of 5-year survival. It also has a big influence on gastric carcinomatosis, and you can see that no patients with PCI more than 19 were alive, even in case of complete cytoreductive surgery and HIPEC at 1 year. Regarding patient selection, in all cases, you will have to evaluate the possibility of complete cytoreductive surgery. And this possibility is most of the time depending from the extent on the small bowel. It's very important to try to evaluate the disease extent of this small bowel, because this is most of the time the small bowel that lead to only explorative laparotomy. And in this field, the laparoscopy as a pivotal tool, because in this small involvement but diffuse involvement that you can see on the photo is not visible on the morphologic exam and is only visible on laparoscopy. So by laparoscopy, your principal goal will be to appreciate the extent of small bowel involvement, and your secondary endpoint will be also to appreciate the involvement of other digestive involvement like gastric and colonic, because most of the time it will be your limit. So laparoscopy should be performed systematically in case of advanced gastric cancer. I show you that the best indication for cytoreductive surgery and HIPEC is for low PCI that are not visible on morphologic exam and that should be diagnosed by this laparoscopic approach to select the good candidate for a curative approach. There is some particularities of laparoscopy in gastric cancer, because sometimes you may have some disease that is not visible, but that could be diagnosed by palpation. So in my institution, for every gastric cancer with independent cancer cells, we recommend a laparoscopy with a monotrocar access in order to be able to do a complete palpation of the small bowel to avoid open and closed procedures for underestimated extent. What about now extraperitoneal disease? Extraperitoneal disease cannot be an absolute contraindication if it's treatable with a curative intent and if this extraperitoneal disease is chemosensitive. This is the case of synchronous liver metastasis, which may represent a relative contraindication, which is not an absolute contraindication. In many experiences already reported into the literature, you can see that the survival results are exactly the same in case of both metastatic disease, but when you have less than 3 metastases, when you will have to perform a limited liver surgery, and when you have a chemo response of liver metastasis. More and more, we will use as medical oncologists the molecular tumor factors in order to select our patients. And you can see that more and more papers are published to try to identify the patients that may benefit for the combined procedures, for an aggressive procedures regarding the genetic mutation. So to evaluate appropriately the candidate for curative treatment of peritoneal metastasis, you have to take into consideration all these things: patient conditions, centers, tumor, peritoneal disease. And if you want to apply a curative treatment of peritoneal metastasis, you should establish in expert centers a personalized therapeutic management. One word now about prophylactic and proactive management. As you can see, we have identified the patients that are at risk of peritoneal disease for colorectal cancer. This is the patient that had some peritoneal disease around the primary tumor, the patient with ovarian metastasis, the patient with a T4 tumor with peritoneal involvement, but the level of the risk of recurrence is not so high in every condition. Dominique Elias was the first to evaluate a proactive management for patients that were at risk and that have a negative workup at the end of the FOLFOX adjuvant treatment. And he did a systematic second look, plus or without HIPEC, if the patient had no sign of peritoneal disease. And he found that half of patients that were at risk had inframorphologic peritoneal disease. Some of them were treated with HIPEC, some others were just treated by explorative laparotomy, and he found that the use of HIPEC was an independent prognostic factor in this small experience. We also have two other reports from the Italian guy that demonstrated that the use of HIPEC for patients without peritoneal disease but treated because of the risk by HIPEC had a lower peritoneal recurrence rate and with an impact with on the overall 5 years survival. It was also the case of this experience from another Italian team that demonstrate that for T4 patients, the use of HIPEC as adjuvant treatment may reduce the peritoneal recurrence. This is the reason why we decided to perform another randomized studies in France, the ProFellowship trials that randomized for this group of patients at risk, the follow-up and the experimental group treated by a systematic laparotomy with a systematic HIPEC. But the ProFellowship study that was also presented in poster in ASCO meeting failed to demonstrate that this proactive management may have some benefit in terms of disease-free survival at 3 years, which was the principal endpoint. And if we can make some remark on this ProFellowship protocol, is that there were no centralized monitoring on the principal objective, unfortunately, and we were surprised to find an higher rate of recurrence in the HIPEC group than in the follow-up group. More than 10% of patients that were supposed to be treated by HIPEC did not receive the treatment and were kept into the survival analysis. We performed HIPEC with Oxaliplatin for patients when we discovered peritoneal disease following a FOLFOX regimen. So it's not adapted from my point of view to perform HIPEC using a drug when the patient progressed under the use of this drug by intravenous administration. And the other thing that we have is that perforated tumor without mucinous component or without lymph node involvement appears to have a lower risk of peritoneal recurrence of less than 30%. But there was also another randomized trials from the Netherlands colleagues that was also negative. The group of patients were different. They evaluated only patients with T4 tumor and perforated tumor, and they did an HIPEC immediately after the resection of the primary tumor. This study was also negative in the principal objective, which was progression-free survival at 18 months. And the only difference that we found between both groups was the higher rate of right side tumor in the HIPEC group. From my point of view, it was in these both randomized trials probably the bad HIPEC and the bad timing. In both studies, HIPEC with high dose of oxaliplatin for 30 minutes was used, and we saw in the PRODIGE 7 that it was not the adequate HIPEC. For ProFellowship, I think that this proactive management is probably scheduled too late, because many patients at risk of peritoneal disease will progress during the FOLFOX regimen and will be discovered on the morphologic exam. And you will perform HIPEC with oxaliplatin for patients that progress under FOLFOX. In the COLOPEX study, you will include some patients that are at risk of peritoneal recurrence, but that are at risk also of systemic disease, and you will delay by doing the HIPEC the beginning of FOLFOX regimen, which is very important for patients with lymph node involvement. So this is the reason why I think that we should take some lesson from these two negative randomized trials, but there is still a strong rationale to try to do something for these patients at risk of peritoneal disease. First of all, we should apply proactive management for patients that have a very high risk. And patients with perforated tumor or T4 tumor without mucinous component or without any lymph node involvement have a risk of probably less than 20%. And this proactive management should not be applied, from my point of view, to this kind of patients. This is what we propose in our centers for these patients at real risk. We begin the FOLFOX for 4 to 6 cycles, and we are performing surgery not too early, not too late, as interval, and we apply cytoreductive surgery and HIPEC with mitomycin C. By this way, we exclude patients that will progress under systemic chemotherapy extraperitoneally, that will receive other regimen of systemic chemotherapy, and we will avoid progression or unknown progression under FOLFOX and treat them as soon as possible. What about now the prophylactic treatment of gastric cancer, which is probably a higher problem, because one gastric cancer over 2 will develop peritoneal disease during their evolution. We know, of course, the factors of the risk factors for peritoneal recurrence, which are laminitis, lymph node involvement, serosal involvement, and positive cytology. We have some meta-analysis that showed that the use of intraperitoneal chemotherapy in gastric cancer may improve the prognosis by decreasing the rate of survival recurrence, but the problem is that there is only Asiatic trials, and we have no Western countries trials. This is the reason why we decided in Europe to conduct the gastricide trial for patients with evolved gastric adenocarcinoma, but without any peritoneal disease. They are all treated by perioperative systemic chemotherapy and curative gastrectomy, and we randomize the use of HIPEC with Oxaliplatin intraoperatively. We already have the results of mortality and morbidity on the first patients, and you can see that HIPEC did not increase the mortality and the morbidity. We are using in this study lower dose of Oxaliplatin because we are in prophylactic setting. I think that the inclusion will be finished at the end of the year. As you can see, we already included 320 patients and 290 patients were randomized. Despite the use of a systematic laparoscopy, we still have 12% of patients that have peritoneal carcinomatosis and that were not randomized in this study. So to conclude, and I would like to say one word about PPAC that we introduced in our center since 3 years now. This is procedures that were introduced and developed by Marc Raymond, a German surgeon that did a lot for peritoneal surface malignancy. It delivered chemotherapy by the means of laparoscopy and by aerosol. This is a palliative treatment. It allows PCI evaluation and biopsy during each procedure to evaluate the pathologic response. This PPAC may lead to homogeneous distribution, as you can see here with the blue that was injected. The tissue penetration of PPAC appears to be better than HIPEC, up to 7 cell layers in this experimental study. And you can use PPAC alone as a palliative treatment, but also, and I prefer this scheduling in combination with intravenous chemotherapy. In Lyon, we are using PPAC every 2 cycles of systemic chemotherapy, and we are performing complete evaluation by CT scan, tumor marker, and evaluation on tumor board every 3 PPAC. It was now well demonstrated that PPAC is feasible and safe and well tolerated, and the preliminary results are encouraging. Which patients? One message: PPAC should not be delivered some days before the end, so you should have an expected life duration of at least 3 months. And this kind of procedures is contraindicated for patients with very poor prognostic, with very poor general condition. We currently have 2 standardized protocols, one using Oxaliplatin, that we are using most of the time for peritoneal disease from colorectal cancer, and cisplatinum combined with doxorubicin that we use for peritoneal disease from ovarian, gastric, or mesothelioma. But this is an interesting way of delivering intraperitoneal chemotherapy, and probably that in the future, new agents should be tested. What about the disease? Of course, we will reserve this kind of therapeutic procedures for isolated peritoneal disease and treated with the palliative intent, but it may be discussed in case of a dissociated tumor response when you have a response of systemic disease by systemic chemotherapy and progression of peritoneal disease, especially if you combine PPAC to systemic chemotherapy. The main and the principal indication is palliative, but more and more teams are trying to use it as a neoadjuvant or as adjuvant into clinical trials. I particularly recommend you the lecture of this review that was performed by 2 leaders in the technique, Mohammad Aliami from Saudi Arabia and Martin Hübner from Switzerland, that did a very extensive review of the literature and selected 45 clinical studies to make the point on the procedures. They summarized the good indication of PPAC, and they compared these indications to the indications of HIPEC. In summary, HIPEC is commonly used with the curative intent, and PPAC is used with the palliative intent. They demonstrated that PPAC is no longer an experimental procedure, but demonstrated in many retrospective, prospective phase 2 trials that it's feasible, it's safety, and it's very well tolerated, especially for the PPAC using cisplatinum and doxorubicin. They also showed that there is many signs of clinical efficiency, efficiency on ascites, efficiency of quality of life, efficiency on tumor response, efficiency of pathologic response. But of course, there is still no phase 3 trials that demonstrated its benefits. So PPAC appears a promising technique for the treatment of peritoneal metastasis and can be combined with systemic chemotherapy. We have very interesting results in terms of tolerance response rates. Now, the main indication of HIPEC is palliative treatment, and of course, this technique should demonstrate its impact on survival, quality of life into phase 3 trials, and probably that HIPEC may be used more and more as neoadjuvant treatment in combination with intravenous chemotherapy. In our experience in Lyon Sud, whereas HIPEC was systematically began as a palliative treatment on more than 500 patients already treated, 15% of patients became, with the use of HIPEC, resectable and may benefit of a curative procedure. Thank you for your attention.
Thank you.
Thank you for your great lecture today, Professor Glenn. At this time, if anyone has any questions, please ask them now.
Thank you very much, Professor, for the excellent lecture. I had a question that I think from the last slide you answered it relatively. My question was, in the case of incomplete cytoreduction, can we consider HIPEC like a contraindication? Yeah.
It depends on the etiology. I cannot show you the results because it was not published, but Cusamira did on the big international registry on Pseudomyxoma peritonei on more than 3,000 patients, study trying to evaluate the role of HIPEC in different subgroups of this disease. And it showed that HIPEC had a significant benefit, not only in patients treated with complete cytoreductive surgery, but also in patients treated with incomplete. In peritoneal mesothelioma, we also have some sign of efficiency of HIPEC in case of incomplete cytoreductive surgery. So in this both etiology, HIPEC could be used even if you are not able to do a complete cytoreductive surgery. For all the other etiology, especially for gastric, colorectal, appendiceal, I think that you should not apply HIPEC in case of non-curative surgery.
Okay. And another just broad question: how can you work with low and middle income countries in terms of since this HIPEC is mostly practiced in specialized center, how can you help those center in low and middle income country to start practicing the HIPEC? Is it something that remotely you can bring an input to the surgeon on the field, and will it require some more technical apparatus to do it, or is there any way at all that this can be done remotely?
I think that it was probably a big error that was performed at the beginning of the adventure of HIPEC. You had one different HIPEC in all the center. Nobody did exactly the same, and it was, as I said, one of the big advantage that we had in France by using the same protocol in the same way, even if we did not choose the good HIPEC, I think. So how can we improve this? I think that all centers that began to treat peritoneal surface malignancy should have education from an expert centers, and we did it in France, and we do it also in Europe by the means of the European School of peritoneal surface malignancy, trying to learn, to teach not only the surgical procedures, but how doing an adequate HIPEC, taking into account all things that are important, the flow rate, the level of temperature, the homogeneity of heat, the adequate administration of drug, etc., etc.
Okay. Thank you.